Welcome to Optic Surgeon, the ophthalmology podcast. Okay, let's set the scene. Picture this. A patient comes into your clinic. They're complaining about an eyelid twitch, It just won't stop.
Uh-huh. Happens all the time.
Exactly. Initially, you think, okay, maybe stress, caffeine, the usual stuff. But then it keeps going, gets worse. The twitches become more like, spasms. And then it starts involving the cheek muscles on the same side.
Okay, now that's raising some flags.
Right. Suddenly you're thinking beyond just a simple twitch. It opens up this whole spectrum, doesn't it? From really benign things to potentially more complex neurological issues.
Absolutely.
So that's what we're diving into today. We're going to really get into eyelid twitch, blepharospasm, and hemifacial spasm. The goal is to give you a solid framework for tackling these kinds of presentations.
Yeah, that's a great way to frame it. Because those initial symptoms can look similar,
Yeah.
but the underlying causes, totally different roads. So let's try and nail down some key differences first. When we talk about that common eyelid twitch, benign eyelid myokymia, think brief, involuntary, really fine muscle contractions, usually just one eyelid,
That little fluttery thing.
Precisely. It's almost always the orbicularis oculi muscle involved. And crucially, these tend to be self-limiting, often tied to things like stress, being run down, too much coffee, maybe eye strain.
Right. I definitely need less caffeine or more sleep twitch. Got it. So blepharospasm, that's a step up, isn't it?
Oh, yeah, it's a different ballgame entirely. Blepharospasm, specifically what we call benign essential blepharospasm, or BB. This involves involuntary, much more forceful, repetitive spasms of the eyelids.
Forceful. Okay.
And the really key thing here, bilateral. It affects both eyes. It might start out subtly, maybe just blinking more often, or the eyes feeling a bit irritated, gritty. But these spasms can ramp up, both in how often they happen and how strong they are. In severe cases, the eyelids can clamp shut so hard that the person is functionally blind, even if their vision itself is perfectly fine.
Whoa, functionally blind just from the spasms.
Exactly. Now, it's important to distinguish BEB from reflex blepharospasm. Reflex is just what it sounds like, the eyelids squeezing shut, because something's irritating the surface. Dry eye, maybe a tiny foreign body.
So fix the irritation, fix the spasm?
Pretty much.
Yeah.
Treat the underlying cause, like the dry eye, and that reflex spasm should resolve. So BEB is the primary neurological condition, while reflex is secondary.
Okay, that distinction makes sense. And then there's hemifacial spasm. The case we started with sounded a bit like this.
Right. Hemifacial spasm is, hemi one side. It's unilateral, involuntary muscle contractions affecting one side of the face. It very often starts around the eye, again with the orbicularis oculi.
Okay.
But the characteristic thing is that it spreads, usually downwards, involving other facial muscles, the cheek, around the mouth, sometimes even the platysma muscle in the neck.
So it travels down the face.
Yeah. And the spasms themselves can be irregular. Sometimes quick little twitches, other times more sustained, almost like a cramp. And here's another clue. Unlike BEB, especially early on, hemifacial spasm can often happen even when the person's asleep.
Interesting point about sleep.
And one more thing, over time, some patients might develop a little bit of subtle weakness on that affected side of the face as well.
Okay, so we've got a good visual on the what's. Now let's talk why. What's actually causing these different spasms?
Good question. For the simple benign eyelid myokymia, the exact mechanism, it's not perfectly clear. But the leading idea is some kind of localized nerve fiber hyperexcitability right there in the orbicularis muscle.
Like a little short circuit.
Sort of, yeah.
Yeah.
A small temporary electrical glitch in that specific spot. Because it's so localized and usually goes away on its own, we don't typically go looking for major underlying problems.
A localized hiccup. Makes sense. What about benign essential blepharospasm, BED?
BEB is thought to stem from dysfunction deeper in the brain, likely within the basal ganglia. These are the structures really important for controlling and coordinating movement.
Ah, the motor control center.
Exactly. So the thinking is there's some kind of faulty signaling coming from the basal ganglia to the eyelid muscles. And interestingly, there might be a genetic component too. Some studies suggest a predisposition can run in families, so asking about family history isn't a bad idea.
Good to know about the potential genetic link. And reflex blepharospasm, that mechanism seems pretty straightforward.
It is, yeah. It's basically a protective reflex. Your trigeminal nerve, cranial nerve V, senses irritation on the eye surface, sends a signal through the brainstem, and triggers the eyelids to clamp shut. Protect the eye.
Makes sense.
It's a normal response, but it becomes a problem when the irritation itself is chronic, like in severe dry eye. The reflex just keeps firing.
A protective mechanism working overtime. Okay. Now, what about hemifacial spasm? That often sounds a bit more concerning.
It often is, because there's frequently an identifiable structural cause. The most common reason is compression of the facial nerve, cranial nerve A7, right where it exits the brainstem.
Compression. By what?
Usually by a blood vessel,
Right.
often what's called the dolichoectatic vessel, meaning it's become a bit elongated and dilated, and it's just pressing or pulsating against the nerve root.
With a hose kinking the nerve.
That's a decent analogy. Less commonly, it could be a tumor in that area, the cerebellopontine angle, or it can sometimes develop after Bell's palsy or another facial nerve injury.
So something physically irritating the nerve.
Exactly, and that irritation can cause the nerve to fire abnormally. There's also this idea of the phaptic transmission, where the nerve impulse might sort of jump across damaged myelin sheaths to adjacent nerve fibers, causing those widespread spasms involving different muscle groups on that side of the face.
Fascinating how a little vessel loop can cause such specific symptoms. Okay, so that leads us to diagnosis. How do we figure out which one it is and what else should be on our differential list?
Right. For the simple benign eyelid myokymia, diagnosis is almost always just clinical, history and exam. It's usually so characteristic and self-limited that specific tests aren't needed. Reassurance is often key.
Easy enough for that one. But blepharospasm.
For both BAB and reflex blepharospasm, recognizing those bilateral forceful spasms is crucial. But a really careful history is needed to tease out triggers for a reflex blepharospasm, asking about dry eye symptoms, allergies, foreign body sensation.
Digging for that ocular surface connection?
Precisely. And a good slit lamp exam, maybe with fluorescein staining to check the cornea and conjunctiva, is vital to look for any surface issues causing irritation.
So history and a thorough front-of-the-eye exam are key there. How about diagnosing hemifacial spasm?
Again, the clinical picture is usually very suggestive, that unilateral pattern starting around the eye and spreading down. But, and this is really critical, neuroimaging is essential. The MRI. Yes. An MRI of the brainstem, specifically looking at the cerebellopontine angle with thin slices, is crucial to look for that vascular compression or, less commonly, a tumor irritating the facial nerve. You have to rule out those structural causes.
Absolutely. Can't miss something treatable or serious there. Okay, now let's broaden the scope a bit. What else could look like these conditions? What are the main differential diagnoses we need to consider?
Great question. That's where it gets interesting. For example, Tourette syndrome. It involves tics, both motor and vocal. An eyelid twitch can be a motor tic in Tourette's, but it's usually just one part of a much bigger picture of multiple varied tics.
So look for the broader pattern.
Exactly. Then there's tic douloureux, or trigeminal neuralgia. That's mainly about severe, sharp shooting facial pain. Patients might grimace or twitch because of the pain, but the primary issue isn't the spasm itself, it's that intense pain.
Pain is the driver there.
Right. Another one is tardive dyskinesia. This comes from long-term use of certain meds, often dopamine blockers. It causes involuntary repetitive movements, often around the mouth and face chewing, lip smacking. But the movements tend to be more complex, maybe more rhythmic, than the spasms in BAB or hemifacial spasm.
Okay, good distinctions. What else might fool us?
Well, synkinetic movements. These can happen after recovery from Bell's palsy when the facial nerve rewires itself a bit abnormally. So you might see the eye closing involuntarily when the person tries to smile, for instance.
Ah, aberrant regeneration.
Exactly. Also, simple excessive blinking. It could just be a habit or related to dry eye or even part of other neurological issues. But usually it's not as forceful or sustained as the eyelid closure in BEB.
More fluttery than forceful.
Yeah. Then there's functional or psychogenic blepharospasm. This can mimic BEB but without a clear neurological basis. The presentation might be a bit inconsistent or have some unusual features. And photosensitivity, bright light making someone squint or close their eyes forcefully. That's a reaction to light, not the spontaneous spasm of BEB.
That's a pretty comprehensive list already. Anything else crucial to keep on the radar?
Yes, definitely a couple more. Myasthenia gravis. This causes muscle weakness that fluctuates, often worse with fatigue.
Yeah.
You can get ptosis, drooping eyelids, but typically not spasms, though facial weakness can occur.
Weakness, not spasm. Got it.
Bell's palsy itself, that's sudden, complete unilateral facial weakness, upper and lower face. Hemifacial spasm usually starts focally and spreads, and weakness, if it happens, is often later and subtler. Ocular cicatricial pemphigoid, a chronic autoimmune scarring conjunctivitis. The inflammation can cause reflex blepharospasm.
Due to the surface damage.
Right. And finally, herpes zoster ophthalmicus shingles, affecting the eye division of the trigeminal nerve. It can cause pain, rash, potentially facial nerve issues, or just ocular inflammation leading to reflex spasms.
Wow. It really highlights how vital that thorough history and clinical exam are to sift through these possibilities. Okay, so once we have a likely diagnosis, how do we approach the workup and management?
Let's start easy again. Benign eyelid myokymia. Like we said, mostly reassurance. Identify triggers, maybe cut back on caffeine, get more sleep, manage stress. Artificial tears can sometimes help if there's associated eye strain, but often it just goes away on its own.
Simple advice for a simple problem. Now, for benign essential blepharospasm, BB.
Okay, for BB, the workup starts with that detailed history and the eye exam to rule out reflex causes. Brain MRI isn't routine, but might be considered if the presentation is atypical or there are other neurological red flags.
And treatment.
The absolute mainstay, the first-line treatment, is botulinum toxin injections. Botox, Dysport, Xeomin. Small amounts are injected directly into those overactive eyelid muscles, orbicularis, procerus, corrugator.
To weaken them.
Exactly. It reduces the force and frequency of the spasms. The effect usually lasts about 3 to 4 months, so patients need repeat injections periodically.
Okay. Are there other options if Botox isn't enough?
Oral medications can be tried, things like anticholinergics, maybe benzodiazepines like clonazepam, but honestly, their effectiveness is often pretty limited, and they can come with systemic side effects, especially in older patients.
Yeah, drowsiness, dry mouth.
Right. So for severe cases that don't respond well enough to Botox, surgery is an option. The main one is a protractor muscle myectomy, where the surgeon actually removes portions of those eyelid closing muscles. It's a bigger deal, obviously. Selective facial nerve neurectomy is another surgical possibility, but it's done much less commonly now.
And lifestyle things.
Definitely worth mentioning. Stress management, getting enough sleep, they might not cure BEB, but they can sometimes help manage the severity or frequency for some people.
Okay, Botox is king for BAB, with surgery for tough cases. What about managing reflex blepharospasm?
That one's all about the underlying cause. Find the source of the ocular surface irritation and treat it effectively. Aggressive lubrication for dry eye, remove a foreign body, manage blepharitis or allergies, fix the trigger, and the reflex spasm should calm down.
Address the root cause. Makes sense. Now let's tackle hemifacial spasm management.
Right. Evaluation starts with that neurological exam to map out the spasm pattern. And as we stressed, the MRI of the brainstem and CPA is non-negotiable to look for nerve compression. Sometimes specialized imaging like CT angiography or specific MRI sequences can help visualize the vessels better.
And the treatment plan.
Similar to BEB, botulinum toxin injections are very effective for symptom control. Injecting the affected facial muscles reduces the spasms. Again, it's temporary, needs repeating every few months.
So Botox works well symptomatically here too, but you mentioned a potential structural cause.
Exactly, and that leads to the potentially definitive treatment for many patients. Microvascular decompression surgery, or MVD. This is a neurosurgical procedure.
What do they do?
The surgeon goes in and finds that offending blood vessel pressing on the facial nerve root. They then carefully place a tiny Teflon sponge or shred between the vessel and the nerve, creating a cushion.
Physically separating them.
Precisely. Relieving the pressure often resolves the spasms permanently, though it's major surgery with its own risks. Oral meds, like carbamazepine or baclofen, might be tried, but they're generally much less effective than Botox or MVD for hemifacial spasm.
So for hemifacial spasm, you have good symptomatic relief with Botox, but MVD offers a potential cure by addressing the compression. Great overview. Before we finish, do you have one high-yield pearl for us to take away?
Absolutely. I think the key clinical distinction is this. If you see unilateral facial twitching starting around the eye and maybe spreading down that same side of the face, think hemifacial spasm first and know that neuroimaging is crucial.
Unilateral equals hemifacial potential and needs MRI.
Right. Whereas if you see bilateral, forceful, often more sustained eyelid closure spasms, think benign essential blepharospasm. That simple laterality and the pattern of spread can really point you in the right direction right from the start.
That's a fantastic practical takeaway. Unilateral spread versus bilateral closure. Thanks so much. This has been incredibly helpful in clarifying these often confusing conditions.
My pleasure. They can seem similar at first glance, but getting those key features straight really helps guide your workup and management effectively.
Absolutely. That's a wrap. Stay focused, keep learning, subscribe.